Hi, I'm Margie Ream, and I'm a child neurologist at Nationwide Children's Hospital in Columbus, Ohio. On behalf of the co-authors, I would like to welcome you to the next few minutes in which I will talk through the findings of our manuscript, Seizures in Childhood Cerebral Adrenoleukodystrophy. So the first question on your mind might be, what is X-linked adrenoleukodystrophy? But in order to understand this, we first must define leukodystrophies in general. Leukodystrophies are a group of rare genetic disorders that affect the white matter of the brain. Symptoms can include loss of motor skills, other developmental delays or regression, stiffness and weakness in the legs, vision loss, seizures, and a variety of other symptoms depending on the condition. X-linked adrenoleukodystrophy is the most common leukodystrophy. It occurs in 1 out of 14 to 17,000 children. It is an X-linked peroxisomal disorder that leads to accumulation of very long-chain fatty acids, which cause inflammation and tissue injury. 3 phenotypes of XALD can occur in males. Adrenal insufficiency can occur at any time during life from infancy on into adulthood. Cerebral demyelinating disease can occur as well in children or men. And myeloneuropathy occurs only in adults. Women who have XALD can develop myeloneuropathy, but usually at a much later age than would occur in men. Childhood cerebral adrenoleukodystrophy, or CCALD, refers to the occurrence of cerebral demyelination that starts in childhood or before 18 years of age. The peak symptom onset for CCALD is between 3 and 8 years of age. We describe disease severity in XALD using 2 different scoring systems. First is the LESS score, which describes the MRI severity or MRI lesion burden on a 0 to 34-point scale, with higher numbers indicating more severe disease. We describe clinical symptoms using the neurologic function score, which ranges from 0 to 25, with points accumulating based on the symptoms in this table. Describing the severity of ALD, symptoms, and MRI disease burden is important because disease severity determines treatment eligibility. CCALD treatment can occur using 2 different modalities. First, traditionally, is allogeneic hematopoietic stem cell transplant, which must be done early in the course of cerebral disease. Prognosis is significantly worse if there's a LESS score on the MRI of greater than 9, and the risk of treatment is generally thought to outweigh the benefit if the LESS score is greater than or equal to 14 and the neurologic function score is greater than or equal to 3. More recently, autologous stem cell transplant with lentiviral-mediated gene therapy was developed, and it also can help if provided early in the course of cerebral disease with a LESS score less than or equal to 9. Both of these treatments can help cerebral disease progression, but do not treat spinal cord disease or adrenal insufficiency. So with this background in mind, I'll go into more of the details of our study. And it's important to note that higher scores with both the disease burden on MRI and clinical symptoms involve an increased risk of complications of disease progression during treatment, regardless of the treatment modality. So our study aimed to answer 3 main questions. First, what is the incidence of seizures in childhood cerebral ALD? What is the relationship between disease severity and epilepsy? And how does timing of seizure onset relate to timing of the first brain lesion? We felt that seizures were an important symptom to describe in childhood cerebral ALD because it is one that often brings children to medical attention, sometimes even before there is a diagnosis of ALD. Seizures can also significantly impact quality of life, so understanding seizure progression with disease progression is very important for maintaining our patients' quality of life. So we conducted a retrospective observational cross-sectional study of patients with childhood cerebral ALD at 2 leukodystrophy centers between 2008 and 2024. And we compared those to patients with X-linked adrenoleukodystrophy without cerebral lesions. So the first question of when do boys with cerebral ALD develop seizures? And the second question for comparison was, does peroxisomal dysfunction in general, without actual brain disease on MRI, lead to seizures? So we had a sample of 86 childhood cerebral ALD patients and 53 adults with ALD without cerebral lesions for comparison. Of the 86 boys with cerebral ALD, 25 had seizures, or almost 30%, while 61 did not have seizures during the course of the study. We compared those to 53 adults without cerebral disease, and only about 5% had seizures. This finding indicated that peroxisomal dysfunction alone, as seen in the adult men, is not sufficient to strongly increase the risk of seizures, while cerebral disease, as seen in these children, was. The occurrence of seizures correlated with MRI lesion burden, as measured by the LUS score. So in this figure, if there were no seizures, the average LUS score in MRI was much lower than if the patients had experienced seizures. And if we separated this data into ranges of LUS scores, seizures basically did not occur with a LUS score of less than 6. This is really important because children can qualify for treatment and strongly benefit from treatment if the LUS score is less than 9. So these children with seizures and a LUS score between 6 and 9 may come to medical attention primarily because they had a seizure. And if they're diagnosed with ALD as a result, they may still qualify and benefit from treatment. As a result, having adrenoleukodystrophy in your differential diagnosis for boys with new onset seizure is very important. Seizures also correlate with a higher burden of symptoms as measured by the Neurologic Function Scale, or NFS. Children without seizures had very low NFS scores, while children with seizures did. They also had a much larger range of symptom severity. It is important to note that seizure occurrence is 1 point in the NFS scale, but even giving allowance for that 1 point, there was a significant difference between NFS for children with and without seizures. We also want to look at not only seizure occurrence, but seizure severity. And we use the seizure severity score as reported in a natural history study of Canavan disease. This score uses a scale of 0 to 2 to describe seizure severity. And this takes into account the frequency of seizures and if patients are on anti-seizure medication. A score of 0 means they did have a seizure, but it didn't recur, and they are not currently taking anti-seizure medication. So when we look at seizure severity, it correlated very closely with LUS score severity and correlated with neurologic function scale. So seizure severity increases with disease severity in childhood cerebral ALD. Finally, we wanted to know if the age of the first onset of the first MRI lesion impacted the risk of seizures, with the idea that if MRI developed lesions earlier, there would be higher risk of seizures. But that actually did not turn out to be the case. The age at first MRI lesion detection was similar between those with and without seizures. What was most important was how severe those lesions were. Next, we looked at seizure characteristics. Of the 15 patients who had seizures and had an EEG that we could review, 4 of them had normal EEGs and 11 were abnormal. All of the abnormal EEGs showed slowing, and only 4 had epileptiform discharges. All seizures reported in our chart review were described as having a motor component. They could be clonic, tonic, or atonic, but none of them were solely staring episodes. This is important to consider because children with childhood cerebral ALD often have auditory processing disorder and cognitive difficulty, as well as inattention. So they may have frequent staring spells, but in our cohort of patients, none of the staring spells turned out to be true seizures. So teaching families seizure distraction techniques is very important to help them determine what events might be seizure and what events are not. We also discovered that routine EEGs are not as helpful in diagnosing seizures in these patients because the minority of EEGs actually showed epileptiform discharges. So clinical history and spell descriptions were primarily the way we diagnosed seizures in these patients. So our findings have some implications for practice. First, seizures are fairly common, with approximately 30% of boys with childhood cerebral ALD having seizures, but not all patients do end up having seizures. Seizures are more common and more frequent as disease progresses. So if you're caring for a symptomatic child, it's important to discuss with families seizure safety, seizure first aid, and response testing so they can distinguish staring spells that are behavioral versus seizures. Seizures do generally have a motor component. And probably most importantly, seizures might be the first sign of X-linked adrenoleukodystrophy in a child, and they can occur when treatment is still an option. So making a quick diagnosis and a rapid referral for treatment evaluation is very important in long-term outcomes for these patients. Thank you very much for joining us, and I hope that you enjoy reading our paper on seizures in childhood cerebral adrenoleukodystrophy.